Okay, so I think without wasting much time, we should start, Dr. Tarun. What do you say?
Yes, we have around 70.
That's okay. They'll be joining. It's fine.
Okay.
Yeah, so guys, good evening. And today, I'm actually, I do not discuss the cases usually. But today, I'm going to discuss this case publicly. Usually, I discuss the cases, short cases in, our classes, right, for our students and in our CCMC classes. But those cases are very specific, and those cases are really specific to prescription audit. Right there, you have seen like I'm discussing a case where I'm asking you people to find out the queries, medication related problems in the prescription, right? But for the first time, I have come up with this case. I've done my PhD in cardiology, so this is my topic of interest, and I have been in the cardio department for many years. So today I'll take you through my experience, how I used to dissect the cases, how I used to, see the cases, and how you all should look into the cases. Actually, when you see the cases as, being a PharmD and, being a pharmacy practitioner, how you should look into the case. Today I'll tell you. And not only this, I'll take you through the guidelines as well. Okay, so this is a demo class as well, because we are starting our clinical internship for the students from this Sunday. Okay, so this is a kind of demo class. I'll not say the complete demo class because demo class will be for 2 hours, and today I'll be taking around 70% part. Okay, 70% part means I'll take you through guidelines, I'll take you through the whole case, and I'll tell you what to cover and how to cover and what are the things to cover in a case. Right, so I hope you will like it. So these all the cases what we are going to discuss in the clinical internship will be the real-time cases. And today also I'm going to give you a full description of a real-time case. Okay, what we have taken from the hospital, from the hospital where I work. So, and for the clinical internship as well, we are calling the people from different parts of India as well as from the, other countries. So they'll give you the glimpse of, how internationally they dissect the cases, how they look into the cases. We'll have the people from Dubai, we'll have the people from USA, Australia. So they'll be also taking the classes in clinical internship. But I'll be taking, Dr. Tarun will be taking. There are many people, many people and experts who will be taking your classes on different subjects based on their expertise, right? So today I will take a simple case of myocardial infarction, and I'll tell you how I dissect the cases, what are the things I look into it. Okay, so let me share my screen. So, and then we'll see. And guys, this class is totally interactive. You all have to interact in between. Okay, because there are multiple questions for you as well. And I'll be asking you many questions in between. You have to, tell me what are the answers and how to, there are the questions related to diagnosis and all. So you have to tell me in between. Okay, so I'll share my screen. Okay, so I'll open my PPTs. Okay, I'll make it full screen. Is it visible, Dr. Tarun?
Yes, Dr. Ajit, it's visible.
Okay, great. So guys, this is a case discussion as well as a demo class. So this session is prepared for your educational purposes. And here, I have taken a real-time case with full anonymity of the patient. So there you cannot come to know what is the patient and who is the patient and what are the other characters of the patient. So you will not come to know anything, right? And that's how we should follow the ethics, and that's how we should present the cases with full anonymity. Okay. So as you can see in the content, I'll present you the case. We'll learn about the diagnosis, differential diagnosis. We'll tell you the different learning points. We'll tell you the treatment algorithm, guidelines, directed medical therapy, prescription audit, discharge plans, patient counseling, and everything. Okay, these discharge plans and patient counseling. Today I'll be covering shortly, not completely. Okay, but in the clinical internship you will get the whole thing in the slides as well, in the class as well. But today I'll be covering these things verbally for 2 to 3 minutes, not completely. And but I'll take you through the whole guidelines of European Society of Cardiology and American College of Cardiology and American Heart Association, what we usually use worldwide, those guidelines. Okay, so this is the case here. This is the case, guys. So a 42-year-old woman presents to the emergency room with 8/10 substernal chest pain and pressure, which was radiating to her jaw, that has been occurring for last 12 hours. Okay, she presented to emergency room with the chest pain and pressure radiating to the jaw for last 12 hours. You have to understand everything. Her uncle, father's brother, paternal uncle, died at the age of 54 years due to cardiac arrest after 3 years of angioplasty to LMCA. LMCA is left main coronary artery, left side coronary artery. So if we calculate the age, he got the myocardial infarction at the age of 51, right? Her uncle. Then she has been started on atorvastatin and fenofibrate for her increased lipid levels 8 months back. Everything is clear here. Okay, in this case, everything is clear. Still you have to tell me. And taking metoprolol 25 mg once daily in the evening for hypertension for past 18 months. Got it? She is taking metoprolol as well, 25 mg for past 18 months. So I hope you understand the case. It is clear. Now, anthropometric and vital check. Patient's weight was 70.3 kg, height 167. So I have calculated the BMI, and BMI is 25.1. Oh, sorry, I think the this is kg. Okay, this is kg per meter square. Okay. So BMI is 25.1 kg per meter square. So in that case, can you please tell me in what category the patient is now? In what category of BMI category? In what BMI category the patient is right now?
Overweight.
Overweight. Great. Right. So the temperature of the patient was 98.7 Fahrenheit. Blood pressure was 168 by 94 mmHg. Heart rate 100 beats per minute. Respiratory rate 18 per minute. No neurological symptoms. So can someone describe these pickle to me? What is this pickle downside? P positive, I negative, C negative, C negative, L negative, E negative.
Pallor is positive, sir.
Pallor is positive. Okay, so P for pallor, I for?
Icterus.
Okay, icterus. And C for?
Sinus.
And again C for?
Clumping.
L for?
Lymphadenopathy.
Lymphadenopathy. And E for?
Edema.
Edema. So this is pickle. Okay, so we check pickle in our physical examinations. So here in this patient, pallor was positive and icterus was not positive. I mean, these icterus, clubbing, cyanosis, lymphadenopathy, or edema was not present. So what does this P positive shows? How can you correlate in this patient or in any patient? What could be the possible diagnosis if the P is positive? What could be the possible laboratory investigations?
Anemia, sir.
Anemia, exactly. So pallor comes when your HB is low, right? When your hemoglobin is low, RBCs are low, so it could be related to anemia, right? Pallor is related to anemia, correct? So these are the anthropometric and vital checks. Now let's go to the lab investigations. So serum creatinine was 1.4 mg per dl, total cholesterol 180 mg, LDL 236 mg per dl, HDL was almost normal but a little lower side, TG 386. So here, total cholesterol and HDL are almost normal. LDL is quite high, not quite high, it is actually very high, and total triglycerides are also very high, 386 mg per dl. Okay, so we can justify that patient was on atorvastatin and fenofibrates, right? Now look at the cardiac biomarkers. CK, creatinine kinase was 300 unit per liter, CKMB was 25 unit per liter, and troponin T was 1.08 nanogram per milliliter. NT-proBNP was 275 pg per ml. So can someone tell me what is the normal range of creatinine kinase, guys?
(22 to 194 units per liter).
Okay, it is 22 to 198 unit per liter. So we can say that CK is quite high. Okay, CK is quite high. So where we use CK? Creatinine kinase.
To check myocardial muscle injury, sir.
Not myocardial muscle injury. I'm asking about CK, not CKMB. CKMB is very specific to myocardium, but CK is for the muscle injury. Okay, so we can say the patient is having some muscle injury because CK is 300. Now CKMB is very much related to myocardial injury, and CKMB is 25 U per L. Okay, unit per liter. So what is the normal range of CKMB? If someone tell me. CKMB normal range is 2 to 25 unit per liter. Okay, so this is just at the higher range. Okay, this is just at the at the boundary, we can say, but not exactly very high, at the boundary of normal range, right? Now troponin T, which is the standard biomarker for myocardial infarction, and that is 1.08 ng per ml. A normal range of troponin T is less than 0.4 nanogram per ml. Okay, less than 0.4 nanogram per ml. And here you can see NT-proBNP. This is the biomarker for heart failure, natriuretic, like brain natriuretic peptides. Okay, N-terminal pro-brain natriuretic peptides. So the normal range is less than 150, but here it is 275 pg per ml. We can say it is slight high, but we can correlate with one thing, guys. Here, listen, this is a learning point here. The NT-proBNP has different ranges in different populations. Populations means like this lady is like in the females, usually in the aged female, it would be 300, but here aged female means more than 60, but this female is just less than 50 even, so we cannot say that normal range is 300. But here why it is considered as normal? Because her creatinine levels are slight high. So we can say in the kidney injuries sometimes NT-proBNP goes high. Okay, in the creatinine, when the creatinine goes up, NT-proBNP also goes up a little bit. Okay, so in the CKD patients, normal range of NT-proBNP is 900 picogram per ml. Okay, in the CKD, chronic CKD, or we can say the CKD patients, NT-proBNP would be 900 pg per ml. In the patients more than 60 years of age, we can consider 300 picogram per ml. Normal adults, it should be less than 150 picogram per ml. In the premenopausal women, up to 5 years after menopause, it should be 300 pg per ml, less than 300 pg per ml. So this lady is also menopausal, and 3 years back, I did not mention this in this, but this lady has menopause in the menopausal phase. So we can see that NT-proBNP is correlating normal here We cannot say that the patient is in heart failure. Okay, but Trop-T is very high. CKMB is the higher level. CK is high. And now look at the ECG. Okay, look at the ECG. Follow my cursor. It looks like there are few things which we can understand. Like there is no ST elevation. So this is not STEMI. Okay, STEMI, ST elevation. ST is like this is see in the normal wave. If you see, I'll show you in the next slide. So here, what this ECG shows? This ECG shows that Q wave in the lead 3 and AVF. Q wave. Okay, Q wave you can see here. PQ here you can see here. A little difference here also depressed, and then you can see this is the lead 2. Lead 3 and lead AVF. You can see AVF here. Here. Okay, lead 3 and lead AVF. You can see Q wave. Okay, Q wave suppression, and then T wave inversion. Inversion means when it goes down. Okay, when it goes down. Okay, it inverts. It does not go up. Okay, usually in STEMI, what will be there? ST elevation will be there. So S PQRS. So normally I'll show you in the next slide how to go. Then I will come back to this. So not this. I think we have to clear this first. So here we can see one more thing here in the V3 here. First let's understand these all. Then you will understand easily. So there are 12 lead. This is 12 lead ECG. Lead 1, 2, 3. AVR, AVL, ventricle. Okay, right ventricle, left ventricle, and these are V1, V2, V3. Okay, these are at the limbs, all the limbs, three, upper limbs and lower limbs. And then you can see these, T wave inversions in the lead 2, 3 AVF, and, ST depression in V5, V6. So ST depression is what? So this is a wave, suppose. You can follow my cursor. This is a wave. It starts with the P, Q, R, S, this, okay, S, and it should go up. Usually it should go up. As you can see in the V4, as you can see in the V4, S, T, okay, it should go up. But here it is depressing. In the V5 and V6, it is depressing. Depressing means it is going down. Okay, this wave is going down. So you can see here, ST depression in V5 and V6. In the both leads, it is going down. Okay, see here, ST depression. Okay, V6 and V5. Now you can see T wave inversion in lead 2nd, 3rd, and AVF. So in the lead 2nd, see T wave. This is the normal T wave. You can see in the first lead 1, lead first, you can see T wave is normal. T is upright. Okay, T is upright here. But here in the lead 2, T is inverting downwards. Okay, T is going downwards. So this is called T inversion, T wave inversion. In the 3rd also T wave inversion. In the AVF also you can see T wave inversion. Okay, in the AVL and AVR there is no T wave inversion. This is the upright T wave. You can see the normal T wave. But in AVF again you can see the T inversion. So this is like non-specific. Okay, this is like non-specific ST elevations, we say. Okay, we call it non-specific T wave elevations, ST wave elevations. Okay, so that's why, I'll tell you this is Anastomy Ecg. Okay, Anastomy Ecg. So there are two types actually, STEMI and Anastomy, and another 2 types, stable angina and unstable angina. So there are 4 types of CADs. Okay, coronary artery disease. There are 4 types. One is stable angina, one is unstable angina, one is STEMI, and one is Anastomy. So STEMI is when there is a ST elevation in the ECG, V4, V5, V6. Okay, 2nd, 3rd, and AVF. But if there are no ST elevation and there are non-specific T wave changes, okay, then in that condition it is called Anastomy. Okay, in that case, in the Anastomy case, you will see that T wave inversion and ST depressions. Okay, ST depressions usually in the lateral leads. Lateral leads means V5, V6, V4, V5, V6. Okay, and sometimes in the anterior leads also, 2nd, 3rd, and AVF. Okay, so these are the anterior and lateral leads. So you can see, there's ST depression and T wave inversions in these leads. So here, okay, so after going through all the tests, all the biomarkers, ECG, and history and patient's full description, can you please tell me the provisional diagnosis, guys?
Can be an Myocardial infarction.
Myocardial infarction, okay.
ACS and STMI.
ACS anastomy, okay. Then only one diagnosis? What about this? Will you consider only MI? Guys,
The
come on.
patient.
Dyslipidemia. That was the first. The patient is on medications as well, atorvastatin and fenofibrate. Okay. When you write
Hypertension.
diagnosis, you have to consider everything, not only the current diagnosis or current symptoms. Based on the current symptoms, diagnosis means everything. When you are diagnosing a patient, that is the challenge. When you are diagnosing a patient, you have to look into everything. You have to look into all the biochemical investigations. You have to look into all the sign and symptoms. You have to look into all the medical histories, all the medication histories. Then only you have to put your provisional or final diagnosis. You cannot just say that, okay, this is the current situation, patient is MI. If the patient is MI along with the emergency, hypertensive emergency, or some aortic dissection, how you will save the patient? Not at all. You have to first decide the provisional diagnosis, all the provisional diagnosis, and based on the comorbidities, based on the other conditions as well, only you can go for the further management. Otherwise you cannot go. Okay, so don't jump just to the current diagnosis. Go to all the diagnoses based on all the lab reports, all the biochemical investigations, all the medical history, medication history, and all the comorbidities, sign and symptoms. Okay, so dyslipidemia. Then
Hypertension.
hypertension. Perfect. Okay, then I'll come to acute coronary syndrome. So can you tell me what are the other discrepancies to keep in mind based on diagnosis, based on other lab reports? What are the other discrepancies in the patients? Whatever we have seen till now.
Anemia.
Anemia, okay.
Angina.
Angina is covered in acute coronary syndrome. Yes, guys. What about this?
Raised creatinine, sir.
Yes, raised creatinine. Then low hemoglobin and pallor.
Yes,
So
sir.
we'll send it for evaluation. Okay, we'll send it for evaluation. But these are the other discrepancies. These are the other minor problems. So first we'll go for acute coronary syndrome treatment. Done. Now I'll come to the learning point one, different ECGs. Okay, you can see all the different ECGs here, and you can define what is stomy and what is anastomy. First, you can see the first picture in the left hand upside. It is normal ECG. Okay, in the normal ECG, this looks like, this P wave looks like this. Then it will start Q. Okay, this is Q wave. This is R. This is S, and this is T. And this loop calls ST segment. This segment called as ST segment. Okay, and this is totally normal. S is going upright and making a T wave here. Okay, S is going upright and making a T wave here. This is the normal ECG. Okay, you can at least understand this. This is a P wave which is going upright, very small. In case of atrial fibrillation, you will see there is no P wave in lateral leads. There will be no P wave in 1, 2 and AVF, 1, 2, 3 and AVF. There will be no P wave in case of atrial fibrillation. Okay, this is just a point you should remember. When you are seeing an ECG, if the patient is having atrial fibrillation, you will not find P wave in the lateral leads. In the anterior leads, like 1, 2, 3 and AVF. You will not find the P wave. Okay. Now, this is normal, and this is Q, this is R, this is S, and this is T.
Yes, sir.
Okay. Now, if you go to the stomy, in case of ST elevation, this ST segment will be elevated at least 10 mm. Okay. If it is more than 1 mm also, it will be considered as stomy only. But in case of severe and urgent treatment, it should be at least 5 to 10 mm. Okay, so you can see here in case of STEMI. Why it is STEMI? Because here ST is elevated. ST elevated myocardial infarction. That's why it is called STEMI. Okay, in case of STEMI, this ST segment will be elevated. You can see the second image, left side downward. This is STEMI. In case of anastomy, there are two criterias. One is ST depression, what we have seen in anterior leads, second, third, and IVF. Correct? We have seen this, and we have seen in the lateral leads like 4 and 5. I mean 5 and 6. We have seen T inversion. T is going downwards, not upwards here. Okay. If you see that there is ST depression and there is T inversion, so you know why we call it non-specific or non-ST elevated MI, because there will be no ST elevation and it will be non-specific. Okay, it will be non-specific. Sometimes it will be ST depression, sometimes it will be T inversion. Okay, it could be anything. So I mean, it will confuse you. It actually not easy to find out. We go for when there is a STEMI, you can directly find out that there is a severe MI, critical MI. But if there is an STEMI, you have to go for confirmation by the check of troponin T. Okay, in case of anastomy, you have to go for the further evaluation with troponin T. Then only you can understand it. Okay, so this is the learning point 1. You should understand what are the differences in different ECGs for STEMI and anastomy and normal ECGs. Okay, understand? Now next thing is learning point 2, different CADs and ACS. So there are 4 types of coronary artery diseases. One is stable angina, one is unstable angina, one is anastomy, one is STEMI. So here they kept these 4 in the sequence of severity as well. Stable angina is not at all severe. Unstable angina is quite severe, but anastomy is needs sometimes immediate treatment, and STEMI means 1 or 2 hours only with the patient. Patient has only 1, 2, or 3 hours maximum to get the best treatment. Otherwise, it is very critical. So STEMI, this STEMI is very critical one. Okay. So how to differentiate stable angina? What is stable angina? Stable angina is like there is a small block. Okay. There is a small block, or what we say, there is a small plaque, atherosclerotic plaque in your coronary artery. It will decrease your demand of, it will decrease the supply of oxygen, but there is no there is no injury. Okay, there is no injury, but the plaque, the atherosclerotic plaque or block, will decrease the supply of oxygen to your heart chambers or heart valve, coronary valve. Okay, so in that case, what will happen? The patient will get the pain, angina. Patient will get the chest pain, and that chest pain will be occurring only on the exertion. When the patient will be going for hard work or for the exertion, then only, in that case only, patient will get the angina or chest pain. Not in the normal cases, not on the rest. Remember this, not on the rest. So in that case, how to go for the diagnosis? In stable angina cases, patient can go for echocardiogram, or patient can go for treadmill test. Okay, one ECG will not tell you anything, because ECG in that case will be normal. Troponin T levels will be normal in that case. Okay, in case of stable angina, so you can put off your mics when you are not speaking, and when you are speaking, then only you can open your mic. Okay. Okay, so in case of stable angina, ECG will be normal and troponins will be normal. But at the little higher side, we'll jump to unstable angina. Unstable angina will be similar to stable angina, but the plaque or the thrombus, the plaque will be ruptured. There will be no infraction of the wall, definitely no. But the plaque or valve will be, the plaque or thrombus, will be moving. Okay, because the thrombus has been ruptured and there are little plaques, or what we say thrombus, in that case we call them thrombus. They'll be moving in the coronary artery. So they are more dangerous because they can cause further injuries to the coronary artery, or they can go to the carotid artery and they can cause stroke. Okay, or they can go to the further deep veins and they can cause deep vein thrombosis. They can go to the pulmonary artery, they can cause pulmonary embolism. They can cause pulmonary embolism, which is fatal, which is almost all in 50 to 60% cases it is fatal. So in that case, again, trop T will be normal, okay, and there will be slight T inversions or ST depressions, as you can see, slight ST depressions, okay, slight ST depressions. In that case also, it is recommended to go for echocardiogram after ECG, and we can go for treadmill test. So why treadmill test is recommended after this? Because treadmill test will exert the patient. Unstable angina sometimes occurs in the during the rest also. Unstable angina also occurs in the when the patient is exerting, but sometimes it is occurring at the rest also, and it is frequent. Okay, unstable angina, chest pain is frequent. So when you will go for treadmill test, you will exert, and the doctor clinician will see what time your ECG is changing based on your pain. When you are getting the pain, and that time only your ECG will show ST depressions or significant inverted T waves. So based on that, they will go for angiogram. Trop T will be normal in that case also. Then they will go for angiogram. Angiogram will tell the length of plaque, the diameter of the plaque, and it will tell how many thrombuses are there and how it is impacting the coronary artery. Okay. Now, if the patient is getting chest pain for more than 15 minutes, okay, chest pain more than 15 minutes, if it is radiating to the jaw or your left arm, that is serious. If you have chest pain, there are many other kind of pains. There are other differential diagnoses. Muscle pain are there, gastritis is there, severe gastritis, sometimes asthmatic, sometimes anxiety, depression, many other pains are there. Okay. Or if you have in the old ages, patient get arthritis, or patient get spinal injuries, or patient get what we say is there are other problems, bone related problems, right? So there are other differential diagnoses. So in that case, when you get the chest pain which is radiating to the jaw and your left arm, that could be serious. In that case, you should immediately meet the doctor, get your troponin done. Okay, get your troponin done and get your ECG done. So now what next? If your ECG is showing ST elevation, okay, if your ECG is showing ST elevation, immediately go for angiogram and further treatment, because the patient is having STEMI. Okay, ST elevation MI, that is dangerous, and in that case patient can die, because ST elevation occurs only when your plaque is covering the whole artery, your whole coronary artery, either it is left, right, anything. But when it is covering both, covering completely, completely means in the circumference, so there is no way for oxygen supply, and it is because of infarction. Okay, it is because of infarction. So in that case, there will be no oxygen supply. There will be completely blocked oxygen supply, or it will be 10%, 5%. In that case, your heart muscles will be dying and the patient will be dying soon. So in that case, when you detect this, you should immediately go for trop T. I mean, it's not necessary in that case, but trop T is recommended, of course, with ST elevation also. And then immediately go for angiogram to check out the, further management, like if you need, balloon angioplasty, or if you need the stents, or if you need the this bypass surgery, CABG. Okay. In that case, you have to go for the further management. But if there is no ST elevation and there is confusing things, if there is non-specific T wave changes, non-specific T wave changes, non-specific ST elevation, then what you will do in that case, you should go for troponin. Troponin will be high. Then if the troponin is high, you should immediately go for angiogram. And after angiogram, you should directly go for the further management, either medications or stents, based on the length of plaque and the diameter of the plaque, how much it is covering. Okay, so more dangerous here are STEMI and anastomy. Now these are CADs. So what are the ACS, acute coronary syndromes? There are only 3 categories which comes under ACS. These 3 categories comes under ACS: unstable angina, STEMI, and anastomy. Only these 3 are coming under acute coronary syndrome, not stable angina. Okay, stable angina can be managed easily and it does not have much symptoms. It does not have troponin elevated or ECG changes, and it can be managed easily. And this is chronic. This is like non-frequent pains, occasional pain, okay, occasional chest pain, right? But in this case, STEMI, anastomy, and unstable angina, you can get, you may need immediate treatment. Sometimes unstable angina also, I mean, it will not be 2 hours or 3 hours, but unstable angina would be like, 1 day or 2 days or 3 days. Okay. So that is also considered as ACS. If it is less than 30 days, if the chest pain is less than 30 days, it will be considered ACS. Okay. So unstable angina, STEMI, and non-STEMI, I mean this anastomy will be considered as ACS. Okay. So now.
Hello. Hi, sir.
Hello.
Sorry, sir. थोड़ा डिस्टर्ब किया सर. सिम्टम्स आर अदर सर. सो अलग अलग सिम्टम्स तो अलग अलग आते होंगे ना सर?
कैसे सिम्टम्स कौन से? लाइक व्हाट सिम्टम्स?
सर सिम्टम्स सारे के जैसे तो स्लाइड पीछे मतलब अगेन करेंगे सर प्लीज. हेलो सर. जैसे स्टेबल एंजाइना के सर, स्टेबल एंजाइना अनस्टेबल के ये सर स्टेबल एंजाइना अनस्टेबल एंजाइना के ये जो सिम्टम्स हैं वो तो अलग अलग आते होंगे ना सर?
नहीं, चेस्ट पेन ही होता है, बट ड्यूरेशन अलग होती है ना. ड्यूरेशन स्टेबल एंजाइना में फ्रीक्वेंट नहीं होता है. इट इज लाइक ओकेजनली. अनस्टेबल एंजाइना इज frequent on the exertion, sometimes on the rest also, sometimes on the rest also.
Okay, thank you sir. Thank you. Okay.
Excuse me, sir.
Yes.
Sir, bypass surgery can only done in the condition of STEMI.
Not necessary. It is based on the percentage of the blocks and number of the blocks, number of the plaques in the arteries, how many arteries are covered. And sometimes when the left main artery is covered, there is at least 95% or more than 95% of LMCA is covered. In that case, patient needs bypass surgery, because in that case, stenting is not proven to have the long-term effects. When LMCA left main, because left main artery is covering the blood supply to your left heart, to your left ventricle, and left ventricle is the main chamber in your heart which supplies the whole blood, or we can say the blood to whole body, right? So if your left chamber is not getting the proper blood, and it is getting the event again and again, this plaques and all again and again, in that case, actually when the research, or what we can say the clinical trials, has compared the impact, the long-term impact of bypass surgery, the CABG, and stenting, this PTCA, they found that both have the similar effects, but for the outcomes, or what we can say the symptoms, the further symptoms or future symptoms are lesser in the CABG. So that's why sometimes they recommend CABG when your LMCA is completely covered, or your left main artery is completely blocked, along with some more branches in the left side.
Okay, sir.
And
Yes, sir.
if it is treatable, like they actually call it based on one scoring system. They consider that scoring system like how far is the block from the main origin. See, left aorta is the main artery which actually supply the blood. So from the left aorta only, main LMCA comes to the heart wall. It is supplying the blood to the heart wall also from the left aorta. So that main left artery is when this is only blocked by the plaques or by the thrombus. In that case, that stents will not work for the long term. Okay, there will, in the clinical trials, they says that there are the high chances of re-events or recurrence of MI again and again. So in that case, bypass surgery or CABG is recommended. Okay, but nowadays I think there are many other drug-eluting stents have come in the market, tacrolimus, stents and all, which can be placed instead of CABG, and which are actually showing the good results in case of LMCA blockage also. Okay, so we'll go to the next slide now. I hope you understand the stable angina, unstable STEMI, and anastomy. So now further test has been done. Echocardiogram has been done, which was showing the regional wall motion abnormalities. Wall motion abnormality means the wall motion will be either nil, or it will be decreased to 10 to 20% or 30%. Okay, when there is no blood supply. So in this patient, wall motion abnormalities were seen in the left side as well as in the right side. Okay, HB of the patient was 9.2 gram per dl. Hematocrit was 31%. TLC was normal, 9,800. RBC 2.2 million cells per microliter. Serum creatinine was 1.9 mg per dl. So now again question for you guys. Okay, so before that, angiogram. Okay, echogram done. Angiogram has been done because the patient has high dropty and her ECG was showing anastomy. So these images are not from the particular patient. These I have taken because those cannot be taken for the ethical purposes. So I have taken these images, exact images from acc.org for your teaching purposes. Okay, because we cannot take the angiogram reports because they have annotated with the names and with the percentages and everything. So we cannot use those for the ethical purposes, but I'm showing you the exact images from acc.org. So you can see the right side of the patient. Here, the right side artery is also blocked. You can see the block. This is the block. See, wherever you can see the narrowing of the vessel, wherever you see the narrowing of the vessel, this is normal vessel. This is the normal size of the vessel. But here, where you can see the white arrow, this is narrowing. Narrowing means there is a plaque. There is a plaque and blood supply here is narrowed down. Okay, blood supply here is narrowed down. So here we can say the right coronary artery has been right coronary artery is blocked, and it has the block here. So percentage, there are the certain parameters, certain radiological scoring systems which are computerized completely, which tells you what is the percentage of the block. Okay, so I'll tell you this is quite high. This is around 80%. Okay, this is 80% right side block in RCA. So this is showing only right side coronaries. And if you look at this is showing left coronaries. So LMCA here you can see, and you can easily see this is blocked. This is blocked. This is not narrowed down, but the blood supply you can see it is very much almost very faded. Okay, it is faded, we can say. And then these are other branches of the left coronary artery only. This is left main. Why it is left main? Because here where you can see the black first arrow, left aortic sinus, here you can see the left aorta. This aorta and this this LMCA is originating from the aorta directly. So this is called LMCA, left main coronary artery. And after this, these are the branches. So first main branch is LCX, left circumference, and then it is left ascending descending coronary artery, LAD, and these are other OM and D. These are other branches which are covering the whole left ventricle. Okay, so this is how you can understand the even angiogram reports. You can see this is not exactly what families are going to do, but still you can understand by this, and you can see how it looks. Okay, you can see how it looks. So this is angiogram report. Now, can you please tell me what is the final diagnosis, guys? Can you please tell me what is the final diagnosis for this patient? Dyslipidemia, I agree. Hypertension, I agree. Acute coronary syndrome, you can see here, anastomy, double vessel disease. What is double vessel disease? There are two vessels involved. One is LMCA, one is RCA, right coronary artery. So LMCA is 88% and RCA is 76% with LCX 55%, which is insignificant. Insignificant means if it is less than 65, less than 70% actually, we do not need stents. We can go ahead with the medicines. And moreover, this patient's two major arteries are blocked. So first intention should be treating those part, LMCA and RCA. Then we'll go for LCX. Okay, then we'll go for LCX. So this is the final diagnosis, three final diagnosis. What is the next? We can see what could be the next final diagnosis, guys.
Anemia.
Anemia. So it could be either iron deficiency or hemolytic. Further evaluation is needed. Okay. We cannot say directly hemolytic anemia or iron deficiency anemia, but it is definitely out of these two, because here RBCs are at the lesser side, 2.2 million only, and hemoglobin is 9.2. So we can say anemia is either iron deficiency or hemolytic. You have to understand these things also. You don't not only the MI, not only the anastomy, but what are the other things going on. Anemia could be either iron deficiency or hemolytic. So we need further evaluations for that. Okay. Then CIN, contrast induced nephropathy. What is contrast induced nephropathy, guys? And why I'm telling this contrast induced nephropathy? Any idea? Anyone?
So because of angiography dye, we have high serum creatinine level.
Yes, but it was 1.4 before also. Okay, so I'll support it. So CIN, why we are telling? Because it was 1.4 initially. That was at the higher level. Higher level is 1.2. Of course, 1.4 was at the higher level. But when we did angiogram, it came up to 1.9. Okay, so that was totally affected by the dye we used in the angiogram. Okay, in the procedure of angiogram. So that's why we are proving it, that it could be contrast induced nephropathy, which will be vanished away in 5 to 10 days or maximum a month. We have to give certain drugs, sodium bicarbonate for a few days. It will be vanished. It will be fine. Okay. So this is the final diagnosis, guys. Dyslipidemia, hypertension, acute coronary syndrome, anastomy, double vessel disease with LMCA and RCA, anemia, and CIN, contrast-induced nephropathy. Okay. Now, what could be the differential diagnosis in the patient? In the beginning, suppose if it is not anastomy, what could be the differential diagnosis for this patient, guys? Differential diagnosis means the other diseases or the other problems or the other conditions which mimic the symptoms of the main problem, which mimic the symptoms. So for that, you have to go for the diagnosis, proper diagnosis. Okay, I'll tell you. One is acute gastritis. Sometimes in case of acute gastritis also, people get chest pain. Okay, and sometimes it is radiating to jaws also, acute gastritis pains. Okay, so how to diagnose anastomy? How to differentiate anastomy and acute gastritis?
Radiating pain.
Radiating pain, no. How to differentiate? Because these are differential diagnoses. How to distinguish? How to rule out?
ECG.
Time duration.
Trop T
Exactly.
levels. ECG.
ECG and trop T levels. Exactly. ECG and trop T levels. Next is acute mitral regurgitation. So that could be only ruled out by the echocardiogram. But before that, we will do ECG and trop T, and this also can be done through the echocardiogram, and that will be doing after ECG definitely. In case of MI also, in case of acute mitral regurgitation also, we'll be doing echocardiogram. Another thing is acute aortic dissection or acute stenosis. That can be found out, not completely. This is not 100% for that, but it could be found out in the echocardiogram. And if there are the signs of acute aortic dissection or aortic stenosis, the patient should immediately go through the what? CT scan, cardiothoracic or computed tomography scan for thoracic area. Okay, for cardiothoracic area, computed tomography scan, CT scan, immediately it should go through. And if it is possible, CT guided stenting or CT guided PTCA should be done for these things. Okay. Then anxiety disorder. Anxiety disorder is the major differential diagnosis for MI. The patient with severe anxiety always have severe chest pain, even moderate to severe chest pain. Okay. And they have the neck pain also, not jaw exactly, but neck pain also. Okay. So anxiety disorder also mimics the symptoms of myocardial infarction. Infective endocarditis, how we can check it out, how we can differentiate, how we can distinguish from the MI. Of course, ECG, Anthropometric, and echo will tell if there is endocarditis. Okay. Then myocarditis, and then pneumothorax. What is pneumothorax, guys? Pneumothorax also have the similar symptoms. There are other multiple diseases which have the similar symptoms, but these are the major which actually comes under the differential diagnosis of myocardial infarction. Not only anastomy, all myocardial infarctions. What is pneumothorax?
Respiratory system.
Pneumothorax is the collapse of lungs. Okay, pneumothorax is collapse of lung or lungs. So in that case also, you can get the similar symptoms. Okay, so these are the differential diagnosis for myocardial infarction, or we can say for the ACS. Okay. Now, we have used our
Excuse me, sir.
Yes, please.
Sir, if ECG is normal and troponin T levels are also in normal ranges, how we can say whether it is of cardiac patient?
No, in that case, definitely we should go for further evaluations. Then we'll go for the evaluations of acute gastritis by ultrasound abdomen, or if in case of acute mitral regurgitation, we can go for echocardiogram. Acute aortic dissection also echocardiogram. If there are signs in echocardiogram, we can go for CT scan. If there is anxiety disorder, we can go to psychiatric. We can go for the psychiatric consultations. But before that, we can do echocardiogram. If echocardiogram is also normal, and in case of, as you are telling, stable angina, in case of stable angina, we should go for TMT. Okay, treadmill test. If treadmill test is negative, then definitely it is not something called CAD. Then in that case, we should go for anxiety, psychiatric consultations for anxiety disorder in case of anxiety disorder. And if it is infective endocarditis or myocarditis, it will be coming in echocardiogram for sure. And if it is pneumothorax, then in that case also it will be coming in echocardiogram. And pneumothorax also can be checked out through CT scan or MRI also, and X-ray also. For pneumothorax, the first diagnosis is first diagnostic criteria is X-ray, chest X-ray. So if you suspect a patient with chest pain, either it is frequent or occasional, the patient should undergo ECG. Okay, ECG at least. If ECG is normal, and if the patient is still, then you can give some, painkillers. Okay, you can give some painkillers, and you can give some Pentosid DSR. I mean, I'm not telling the treatment exactly, you should not do this, but I mean, this is the basic treatment what we usually give, what clinicians as usually give. So if it is not subsiding by that, then you should go for one echocardiogram and treadmill. Okay, and if treadmill and echocardiogram is normal, then you can go for the further evaluations of acute gastritis or whatever is whatever the clinicians feels okay. It is echocardiogram will define almost many things, mitral regurgitations or aortic dissection, aortic stenosis, myocarditis, like infective endocarditis, pneumothorax, everything will be almost covered in that. But if the patient is anxiety disorder, definitely, psychiatric consultations are needed. If acute gastritis, then you can go for, what we say, ultrasound abdomen and pelvis, USG abdomen. So that is the, what we say, the plan of diagnosis in that case. Okay, so now SOAP and F analysis. We usually call it SOAP analysis. You PharmDs also, we PharmDs, do SOAP analysis, that is subjective, objective, assessment, and planning fact. But I have added one more thing, SOAP plus F analysis. F is follow-up. Follow-up is also necessary in case of cardiology. Because if you are not following the patient for medications, for the symptoms, for the recurrence, for the medication compliance, it will not be well and good, because patient can develop anything anytime in that case. So follow-up is very much necessary. So here we did subjective. We checked all the sign and symptoms, all the clinical presentations. We did objective, medication history, family history. Patients family history was very strong. Paternal uncle had the myocardial infarction. He died due to cardiac arrest. He died due to myocardial infarction as well. So, and patient is on hypertension. So hypertension is one of the risk factor, and dyslipidemia is one of the major risk factor for MI, myocardial infarction, or we can say the ACS or CKD, CAD, coronary artery disease. So both the things we have objectified in this. And now assessment, we did all the lab investigations, we did all the imaging, including echocardiogram and coronary angiography. Okay, CAG we did. Okay, now next thing is problem list. We concluded our final diagnosis. Now what next? Planning or management for the patient. Okay, and then follow up. So this is SOAP analysis. So this is how you can even do the your case under SOAP format. Okay. Now learning point 4. What are the risk factors? So guys, can you please list out the risk factors of myocardial infarction or risk factors for CAD?
Sir, smoking, alcohol.
Smoking, alcohol, hypertension, diabetes. Okay.
Anemia as well.
Anemia as well. Okay.
Sedentary lifestyle.
Obesity.
What is that?
Obesity, anxiety.
Anxiety. Okay.
Sir, headache.
Sedentary lifestyle, sir.
Elderly patients.
Drug induced. Okay.
Sir,
Sedentary
headache.
lifestyle.
Which? Sorry.
Obesity. Dyslipidemia.
Dyslipidemia. Okay. So hypertension, diabetes, smoking, alcohol intake, tobacco chewing, hyperlipidemia or dyslipidemia, definitely. Family history. So guys, there are two things. One is major risk factors, one are minor risk factors. So these all are major risk factors. Okay. These all are the major risk factors for ACS. Major risk factors: hypertension, diabetes, smoking, alcohol intake, tobacco, hyperlipidemia, family history. So you can understand hyperlipidemia is directly associated with sedentary lifestyle and your food intake and your anxiety as well. Okay, and it could be genetic as well. So these are not only one thing, these are associated with other lifestyle modifications or lifestyle adaptations as well. These are not only we do not have to mention everything here, but hyperlipidemia and your diabetic status are associated with your sedentary lifestyle, sitting jobs, and no workouts, and it will be associated with your anxiety. It will be associated with your food intakes, how you are taking red meats and all. So it is associated with other things. These are the outcomes of those points, right? These are the outcomes of those points. Not only your increased lipids. How did your lipids increased? That is main part, right? How did your lipids increase? That is main part. You have to consider, then you have to find out the risk factors for increased lipids, right? So this is not only one thing. You have to go for the sub-analysis of risk factors as well, right? Sub-analysis of risk factors, we call it. Correct. So these are the major things. These are the minors. What I am, clicking now. One is respiratory problems. Yes. COPD and asthma are majorly related to cardiac problems. Injuries, digestive problems, yes. ESRD, okay, and your other digestive problems like peptic ulcer diseases, okay, and other problems, ulcers can be associated with your cardiac problems. Neurological problems, yes, neurological problems, hemorrhage and other problems could be related to your cardiac problems. Infections, majority of the infections are, if those are long term, those will cause, what we say it, multi system, what we say it, guys, what we say it,
multi-system organ failure.
exactly, multi-system organ failure. So that could be related to your infections, okay. And cardiology, or what we can say, heart is the most important vital organ in your body which is affected directly by the infections. Then gender, women gender is quite safer than males, okay, for the ACS or for the CADs. Female gender is quite safer than males, so males are getting more problems than females. These are the minor risk factors. Of course, there are hundreds of the risk factors. You can count me hundreds of the risk factor: anxiety, depression, and there are drugs.
So rheumatic fever.
Age.
Age, definitely. Age is also related to the myocardial injury. That is again, in the minor, not major. Of course, age is related to that. So I cannot list out everything here, but these are the certain major and minor risk factors for your ACS. Okay, guys. Anemia, yes. Anemia is also, causing myocardial infarction.
So
Because
rheumatic fever.
rheumatic fever, yes, minor, definitely. Okay, so now physiology, pathophysiology of clot formation. Okay, I'll take you through the pathophysiology and you will understand in how it actually starts. Okay, how the thrombus formation happens. Okay, actually. So you can understand it by this. So how it happens, think your vessel. Think you are looking into a coronary vessel. Okay, imagine you are looking into a coronary vessel. Coronary vessel is very wide, 2 into 2 meters, what we can say, 2 into 2 meter water pipeline. Okay, 2 into 2 meter water pipeline. Now in that blood is flowing. That is your coronary artery. You are looking into that. So there are certain foreign particles. There are certain foreign particles in your blood which are flowing along with. So these foreign particles would be either fat particles, calcium, or maybe drugs, okay, or maybe some unwanted particles. Okay, it could be anything. It could be anything. Those are directly hitting your wall here and there, right? You will understand it today how the clot clot formation happens. You will understand definitely 100%, I'm sure. So you are looking into the vessel. So there are certain particles which are, we call them foreign particles. So because those are not the part of blood. Why we are calling them foreign particles? Because those are not the part of blood, your usual blood components. Those are not blood components. It could be fat, it could be calcium, it could be, your other substances, or, your maybe some drugs. Okay, it could be nicotine. So they are hitting the wall here and there. Suppose one foreign particle hit it hardly, your vessel hit it hardly. So when it hit it hardly, there is an injury, a small injury, very small injury in the blood vessel. There is a small injury. So what will happen now when there is a small injury? There will be two things. Two things will be activated immediately. Two things will be activated immediately. One is tissue factor. Another is, your platelet factors. Okay. Someone's mic is on, guys. Please look into it. Okay. Another will be your collagen and your what we say it, von Willebrand factor. Okay, VWF. These things will be, immediately start releasing from the injury site. One is tissue factor, one is VWF, what is called is, von Willebrand factor and collagen. These three will be start releasing immediately. And these three will attract platelets. These three will attract platelets to bind. So you can see here, where you can see this, fire star, you can see that here it happened, injury has happened here. So these blue and, we can say these red particles are VWF and collagen, von Willebrand factor, and these are platelets. So these attracted the platelets because platelets are also flowing in the blood. These attracted the platelets, and they all are, now attracting the platelets to each other because they are now stuck with the wall of platelet. Now they are attached to the wall of platelet, and now platelet is activated. These VWF and collagen has activated the platelets. So that is called platelet activation. First, these are stuck to the wall of platelet. That is called platelet adhesion. These are attached to the platelet wall. Now platelets are activated because many things happened in the inside the platelet. Serotonin, epinephrine, collagen, thrombin, thromboxane A1, secretion has been started. ADP has been converted into ATP. Sorry, ATP has converted into ADP. Okay. And then these platelets are activated. When these platelets are activated, these will call other platelets to get attached. That is one cycle. Another side, tissue factor has been, started releasing from the injury site. Tissue factor. So this tissue factor, what it will do, it will convert factor 7. Factor 7 is the factor in your blood. Again, blood is full of your clot formation particles, or we can say
Extrinsic pathway, no sir?
yes, it is extrinsic pathway, definitely. So there are not only extrinsic, intrinsic and extrinsic clotting pathways, both are activated here. So how it will go? First factor 7 will be converted into factor 7A, activated. Okay, so everything will be converted into activated. So this tissue factor will activate factor 7 into factor 7A, and this factor 7A, tissue factor 7A, will convert or will activate factor 9 to 9A, and this 7A and 9A will convert factor X to factor XA. Can someone tell me what is factor X called? What we call it? Sorry? Thrombin. No. There is a name, a specific name, guys. You search it, okay, later. So it converts factor X into factor XA, 10 into 10A, and then factor 10A converts your prothrombin into thrombin. So what is the factor? What is prothrombin?
Stewart factor,
Clotting
X.
factor 2.
Clotting factor 2. Factor X is Stewart factor.
Stewart factor.
Yes, factor X is Stewart factor. Now this Stewart factor will convert prothrombin or 2 into 2A. Okay, it will convert 2 into 2A, prothrombin to thrombin. And then thrombin will convert fibrinogen into fibrin. Fibrinogen is again 1A, 1 to 1A. Fibrin means the mass. Okay, fibrin will go to the platelets, where the platelets are aggregated, and it will cover those platelets into a mess just to make that bond strong, so platelets cannot go away, or platelets cannot be scattered now. Okay, so this will bind all the platelets and all other blood factors, blood components like dead RBCs, dead WBCs, TLCs, and other calcium particles, other fat particles, whatever comes in the way, it will come and stuck to this plaque, stuck to this thrombus. Okay, and then it will increase the size. So how it increase the size actually define the type of MI. In stable angina, it is very, very slow, very small. In unstable angina, it is quite speedy. But in case of anastomy or stomy, it is fastest. Okay, it is severe injury, severe clot formation, and severe blockage. Okay, that's how the thrombus has occur, it occurs in your blood vessel. Got the point? So there are many particles, not only Wall-Willebrand factors. There are other GP2B 3A receptors, which also take part in the platelet activation, and these aggregate all the platelets and make a mess or clot with the help of fibrin. Fibrin tighten this mess, tighten the clot, and makes it strong. Okay, so I hope you got it, guys.
Excuse me, sir.
Yes.
Could you just repeat after fibrin formation?
See, when fibrin is formed, fibrin will go to the clot, or will go to the platelets which are aggregated together with the help of other platelet factors like VWF, collagen, and GP2B3A receptors. So these all platelets are aggregated. Now fibrin will go there. Fibrin will make a mess around platelets. Okay, and it will tighten that bond. It will tighten that bond, and it will make a full-fledged clot that will catch other particles from the blood components, not only blood components but other foreign particles also, and it will make that clot strong. It will make that clot strong. Okay, and that's how it blocks the way for oxygen supply. It blocks the way for blood flow. Okay, so now initial treatment immediate after provisional diagnosis. Okay, guys, so if you are aware of cardiology, if you are posted in cardiology, can you please tell me what could be the initial treatment?
Streptokinase.
Provisional diagnosis, immediate after provisional diagnosis. We have finished even final diagnosis. We have finished physiology.
Streptokinase.
Sorry?
Streptokinase.
Anti-Platelet.
Streptokinase, sir.
Fibrinolytics. And
Sir, TPA, tissue plasminogen activator.
Okay. No, more options. I'll tell you. I'll define you everything. Don't worry. Yes, more options, guys.
Anti-platelet.
Anti-platelets. So now there is a catch. There is a catch how to define this. Suppose if your patient is diagnosed with anastomy or stomy, or suppose stable angina as well. Sorry, unstable angina, which is quite frequent. And you can make it out. Your trop T is high in that case. Okay, and the patient is in remote area where there is no catheterization lab, where there is no tertiary care center, where you cannot go through the PTCA or bypass or any angioplasty. In that case, definitely you have to go to fibrinolytics. Okay, because in that case, patient could die within 2 hours or 3 hours. So there is a timeline, definite timeline. If the hospital, if the catheterization lab where you can find out, where you can do angioplasty and angiography, if it is 6 hours away, 3 to 6 hours away, in that case, in the case of stomy and anastomy only I'm telling, in that case, patient can be administered with fibrinolytics. Okay, patient should be administered with fibrinolytics, and immediately it should be started on anti-platelet agents.
platelets.
Got it? If you are around the tertiary care center where angioplasty and angiography facilities are available, no need to go for fibrinolytics. Because at the end, definitely, again, if the blocks are serious, you have to go for angioplasty or bypass surgery. So in that case, it's not needed. Okay, in that case, it's not needed, right? So understand, if the patient is in remote area and you are very sure that patient cannot reach the hospital within 2 hours or in less than 2 hours, definitely administer one. What is the choice of drug, guys? In the fibrinolytics, what is the choice of drug?
Ticagrelor.
Ticagrelor. Fibrinolytic. Come on. Ticagrelor is anti-platelet. What is antithrombotic or thrombolytics? Tell me. Retiplase.
Altiplase.
Altiplase is actually for stroke. Usually we give it in the stroke, that is FDA approved for stroke. But for MI also we can use. And recommended drugs for MI are retiplase, urokinase, or tenecteplase. Okay? Retiplase, tenecteplase, or urokinase. Altiplase is recommended for stroke. Okay? Yes. Sir. Yeah. So now what should be the treatment in this case? First should be the aspirin 325 mg 1 tablet stat, ticagrelor 90 mg 2 tablet stat, atorvastatin 40 mg 1 tablet stat. I'll ask you about every drug, every dose, plus IV UFH 400 plus enalapril, metoprolol. Okay, sorry. So guys, describe me why these doses and stat immediate after provisional diagnosis. What are these called actually?
Loading dose.
Yes, this is loading dose. So whenever you are giving to the patient, you have to give a loading dose of anti-platelet drugs. And along with that, along with anti-platelet drugs, statins also. Okay, so this is a drug combination for MI or ACS. You should start with the loading dose, one dose, highest one. Aspirin 325, ticagrelor 180 mg, in one shot. Ticagrelor is available only in 90 mg. So we have to give 2 tablets. Aspirin 325, 1 tablet immediately. Once you find out that patient is STEMI or anastomy or unstable angina, unstable angina, immediately give these drugs. Why acetylcysteine 600 1 to 2 mg 1 to 2 tablets stat? This is for this patient. I'm asking the concern of this patient.
So because of the pain.
Pain. Acetylcysteine can help in pain. Really? What is acetylcysteine?
Mucolytic.
Mucolytic. Okay. So how it will help? What is the exact indication for acetylcysteine here?
It's a precursor for glutathione.
Okay. Yes. But why we are giving here?
To relieve the chest condition.
Yes. And we are giving for not the chest pain exactly. We are giving here. There are two things. No. Yeah. Breathing problem is yes, minor indication. But majorly why we are giving? Because it will decrease the gastritis effect of aspirin. High dose. Because patient has to undergo angiogram and angioplasty, so acetylcysteine will decrease the effect of gastritic effect of aspirin to suppress the gastritic effect of aspirin. And what? Okay, you find out and read it. Okay, why acetylcysteine is given just before the procedure, just before the angiography or angioplasty. Okay, Then why IVUFH? And what is this?
So, for sedation?
Oh no, acetylcysteine is not for sedation. No. Acetylcysteine is not for sedation. Not at all.
So for cystic fibrosis.
No. The patient is not having cystic fibrosis. Okay, you find out later and you correlate with this patient. Okay, tell me about UFH.
Unfractionated heparin.
Unfractionated heparin. Give me the example of unfractionated heparin.
Enoxaparin.
Enoxaparin?
Deltaparin. Dalteparin.
Okay. Deltaparin, enoxaparin, yes. So why we are giving enoxaparin here? Why we are giving enoxaparin here?
It's a thrombolytic.
Not exactly. This is not thrombolytic. This is prophylaxis. Enoxaparin is prophylaxis, and it will help in the procedure. We need it for peri procedure. This is like peri procedure prophylaxis. Okay. So when we do procedure, angioplasty or angiogram, in that case, we should not get any clot, because due to catheter, there are the high chances of other injuries, and there must be, there are the injuries due to catheterizations and tubes and everything what we insert. So to prevent the peri-procedure clotting, we give high dose of fractionated heparin only during the procedure. I mean, not only one shot, maybe 2 shots, 3 shots, depends on the duration of the procedure, every half an hour. Okay, it is like peri-procedure prophylaxis. Remember this, peri-procedure prophylaxis. But we cannot give it in the normal. Why we cannot give it in the normal in this case? If the patient is not undergoing any procedure, why we cannot give?
Embolism. It will cause embolism.
Bleeding, not embolism. Bleeding, hemorrhage. Because patient is already on 2 antiplatelets, aspirin and ticagrelor. So we cannot give unfractionated heparin in that case. Okay. Now these are the other 2 drugs which are for hypertension, and atorvastatin is there already for dyslipidemia. So this is the initial treatment. Now this is the further treatment in the hospital, guys. So you can tell me if anything is mistaken here. Let's do the prescription audit here for a little bit. Then I'll take you through the guidelines. Okay, separately guidelines. So this is.
Before this, I wanted to ask you something.
Yes, please.
So as we talked about loading dose.
Yeah.
So how we decide whether we have to give all that 4 drugs or we have to give like only 2 or 3 of them?
No, 3 are mandatory, definitely. 3 are mandatory. Aspirin, clopidogrel, or ticagrelor, or prasugrel. Okay, so there is okay. Now I want to tell you one more thing, guys. Here, one more learning point here. So, antiplatelet drugs combination. This is called dual antiplatelet therapy, DAPT, dual antiplatelet therapy. So in dual antiplatelet therapy, there will be one COX inhibitor, that is aspirin. So in the COX inhibitor, there is only one drug, that is aspirin. Traditional, latest, 5th generation, that is only aspirin. There is no other drugs in COX inhibitor. Okay. Then next is P2Y12 inhibitor, or we call it previously we call them thiopyridines. Okay, but now we call them P2Y12 inhibitors because they are working on cytochrome P2Y12. Okay, and they are inhibiting that. So first drug was clopidogrel in that category. Okay, and still we use clopidogrel in many cases. Clopidogrel. Okay, and then it came prasugrel. Okay, prasugrel was the next generation of clopidogrel, and then in 2017 in India, it came with ticagrelor. Okay, ticagrelor is very recent drug, very new drug, and it is highly potent than clopidogrel and prasugrel. That's why we prefer ticagrelor. It is costlier than clopidogrel. Previously, initially it was very costlier, like 70 rupees per tablet or 75 rupees per tablet. and one-day therapy would be really, really high. But now, because because AstraZeneca's patent has been gone, because it was only for 5 years, they lost their patent now. So now you can, take this tablet in 25 rupees, 26 rupees only. Ticagrelor. Previously, this treatment was really, really costly. That's why, people or clinicians even would have not been preferred ticagrelor over clopidogrel. Clopidogrel has less efficacy than ticagrelor, but the cost effectiveness, because if the patient is not taking tablet at all due to financial problems, then what is the use of ticagrelor or clopidogrel? So in that case, we always prefer clopidogrel, right? But nowadays, ticagrelor has already come down to 25, 26 rupees. So we use ticagrelor in most of the patients, but still in the patients who are in the BPL or whose financial problems are really, really tough, who cannot afford the medications, we always go for clopidogrel. But still, in the latest guide, in the latest scenario, in the latest practice, evidence-based practice, we give ticagrelor at least for a month, at least for 30 days. First 30 days ticagrelor, then we switch the patient to clopidogrel based on the affordability. Understand? And the third drug in this DAPT, the DAPT, there is ecosprin and ticagrelor or clopidogrel or prasugrel. But along with that, why we give statins? Because statin is another drug which helps in controlling the plaque formation, because it is controlling the fats, it is controlling the cholesterol, but it also suppresses the COX. Okay, remember this. Your statins also suppresses the COX. So it helps, or we can say it increases the efficacy of aspirin. Okay, that's why that is the third drug in the combination. So these three drugs are very much necessary. Fourth drug could be pantoprazole or acetylcysteine. Acetylcysteine, why we give acetylcysteine? Because patient has to undergo procedure. Okay. Otherwise, we usually add pantoprazole. Okay. We use pantoprazole.
Mister, is the frequency of atorvastatin, is it right? It should be given at night, right?
Yes, that's why I'm asking you, because there should be there. I intentionally made some issues in this prescription, so you guys can tell me what are the issues. So that's how you go for the prescription audit. So guys, I'm not going through whole prescription audit now, okay, because that will take time. In classes, you will get whole prescription audit, counseling and everything. But in the prescription audit, what you should go through? You should go through the medication errors. Medication errors in case of, there are many types of medication error: typing errors, dosage errors. Dosage error means sometimes they write, syrup to tablet and capsule to tablet or tablet to capsule. That is dosage form. So you should start your prescription check with dosage forms, whether all the dosage forms are correct or not. Then you should go for spelling check, drug spelling check. Then you should go for the dose. Dose means either it is 75 or 100 or whatever. If the dose is correct or not, if the dose is actually marketed or not, if it is available in the market or not, because then it will create problems to the patient, right? It will create problems to the patient to get the drug in the market, right? Then you should go for frequency. Either the drug is given on the right time or not, right? Frequency, maybe, it will depend. Again, the dose and frequency will depend on the risk benefit ratio, how the clinician looks into the patient's condition, how the clinician looks into the comorbidities. It depends on that completely. But if it is really wrong, then you can intervene. Like you can see here, enalapril dose. See, enalapril ka spelling I have written wrong. Okay, I have written wrong enalapril ka spelling. You can see it is wrong. Dose also it is wrong. Enalapril is available only in 2.5 and 5 or 10. Okay, 2.5, 5 and 10. Right? So you should look into the doses, you should look into the names, and then you should look into the ticagrelor dose. Ticagrelor dose is maximum recommended dose, and minimum recommended dose even is 180 mg per day. 180 mg per day. I have written here 90 mg, 0, 180 mg. Okay, so you should correct it. You should intervene for this. Then Frusilec DS. It is required here. It may be required here based on the patient's fluid volume or volume overload. The doctor may be, may have given this. It is a low dose. of diuretics or furosemide, it might be recommended. Okay, leave it. Atorvastatin should be given in the night, definitely. Why it should be given in the night? Because cholesterol synthesis, or we can say the fat synthesis, is higher at the night time when the person is sleeping, and that time we need the atorvastatins or statins most, so it should be in the night. So not only dosage form, not only spellings, not only correct name, not only units, not only your dose, not only frequency, but special instructions also you have to look into it. Special instructions means, as I'm talking about atorvastatin, it should be given in the night. Pantoprazole should be given in the morning, right? Then along with that, these are the medication related errors. Along with that, you should look into the risk benefit ratio, like drug interactions. Okay, drug interactions, whichever is causing interactions. In this chart, we can see ticagrelor, ecosprin, and clexane, enoxaparin, or no, sorry, not enoxaparin, clexane is given. Why clexane is given? No need of clexane here, right? Because it can increase the bleeding risk very, very high. So we don't need clexane here. So we have to cut the clexane from our prescription here. Okay, we have to cut the clexane from our prescription here. It is without indication. If it is written only for the day of procedure, we can understand either enoxaparin or clexane, definitely, because it is peri-procedure need. It is a requirement during the procedure. We can give. But if it is out of the procedure, it is written here day 1 to day 3, not at all recommended. Drug without indication, we can give it and we can remove it from the chart, right? And side effects. You have to check for side effects. Now, there is one more problem. Can you find out one more problem in this, along with that, what I told? Do you really think omeprazole is recommended with ticagrelor?
No.
No. Omeprazole is not recommended with P2Y12 inhibitors at all, not at all. It will cause severe interactions. So here it should be either esomeprazole or pantoprazole or rabeprazole, but not omeprazole. Even rabeprazole and esomeprazole are not recommended much. Only pantoprazole can be given here. Okay, because omeprazole can completely inhibit the effect of P2Y12 inhibitor. Okay, it can completely inhibit the effect. So omeprazole is not at all recommended. So that's how you look into the prescription. That's how you audit the prescription, everything. You should not leave a single chance. You should not leave a single thing in that. Okay, so this is a short introduction, we can say, I have given to the prescription.
Right.
Yes, please.
So why not any antibiotic is prescribed as a prophylactic drug?
No, patient has not undergone bypass surgery. It has undergone just angioplasty. Angioplasty is not a procedure where patient will get infection. It's just a minor cut either on your hand or on your groin area. That's all. It's just a simple cut, not at all something invasive. Very much invasive where you will get big cuts or big surgeries and all. No. Why antibiotics? Not at all recommended, I feel. I mean, not at all recommended actually in this case.
I mean, not at all as an prophylactic drug?
No, antibiotics are not recommended because there are, there are no chances of, infections, because when you do, either you do radial. So there are two procedures for, two usual procedures for doing angioplasty PTCA. One is radial. So what they do, you can see in my hand here. So let me keep the laptop like this. So either they insert the catheter through here. So they will cut just, maximum 1 centimeter, hole they will do, and they will insert all the catheter from here only. Or they will cut your groin area, only 1 centimeter cut. That's all. From that only they will insert all the catheters, all the wires, all the stents, and they will put in your heart. That's all. And then after that, immediately they will put the whole hemorrhagic treatment, and they will put all the bandages and all. So there are no chances at all for antibiotics, and there are no chances of infections. There are very much less. I'll tell you because I read this. So there are only less than 2% chances of infections in groin areas, only when there are hemorrhages. Otherwise, not recommended.
Thank you, sir.
Okay, so this is done. So further management, yes, okay, I forgot this. So further management for this patient was done, like, patient was undergone PTCA, percutaneous transluminal coronary angioplasty with drug-eluting stents. So drug-eluting stents were placed to LMCA and RCA because there were major blocks more than 70%, right? And then patient was discharged on these medications, right?
Sir, patient is anemic, right?
Yes, patient is anemic.
So no any medication for that.
Exactly. You got the point. So there is anemia which was not given, which was not treated, right? So we have to give iron supplements here to the patient. Or we can suggest the nutrition as well. Nutritional values, we can suggest the patient to meet the nutritionist and to improve the diets. Okay. Because the anemia is not like severe. In that case, I can say it is not severe because 9.2 in women is minor. I'll say not even severe. So in that case, nutrition can be would be helping, or we can start iron supplements on alternate days in the nights. So that will also help for a month or 2 months. We can prescribe. So there is no problem at all. Okay. And for CIN, for contrast-induced nephropathy, in this case, we can recommend sodium bicarbonate for 5 days. Okay, we can give sodium bicarbonate for 5 days. Patient would be fine. If after angioplasty, creatinine levels are really high, like 3 or 4, in that case, we can suggest for one dialysis, only one dialysis. So in one dialysis, everything dye will clear out from the body and patient will be perfectly fine. Okay, patient will be perfectly fine in that case. So
why did we stop giving aspirin? Why did we stop giving aspirin, sir?
Oh no, look at the first drug. Ecosprin is aspirin 75 mg 010.
So, sir, with Ecosprin, if we give iron supplements, then it may irritate the gastric, like stomach lining.
Yes, but we are giving PPI also. We are giving PPI also, pantoprazole. I have written omeprazole replacing pantoprazole, but pantoprazole was given. Omeprazole, why I have replaced? Because to teach you, like it could be a severe potential, drug interaction. But PPI has been given to the patient.
Hello, sir. But iron supplements get breakdown into acidic medium only, no, sir?
No, see, that's why I'm telling iron supplements can can break down into the further things. But I told when I was telling it could be alternate days. In that case, when patient is not in the severe conditions, it could be given on the alternate days. One tablet, alternate nights. It won't create any problem. Dose is very important. Dose adjustment.
Sir, does the patient have angina also?
No, why patient will have angina now? Because patient has underwent all the treatments. Patient has underwent LMCA, RCA, drug-eluting stents. Patient is on drugs now. Why it will have? Why she will have angina? Patient is recovered. Patient is recovered. Blood pressure is in control. Everything, it will come in the follow-up. Blood pressure is controlled. Everything is nice. Patient is following up good now.
Sir, acetylcysteine is for prevention of contrast-induced nephropathy.
Exactly. Now you got it, right? Now you got it. One is to suppress the aspirin's effect. Another is to reduce the contrast-induced nephropathy.
But you said some sodium bicarbonate also here. I
No,
didn't get that.
sodium bicarbonate is the treatment. Sodium bicarbonate is a treatment. Acetylcysteine is prophylactic. Acetylcysteine we have started even before angiogram. Got it?
Yes, sir.
Yes. That we have started before even procedure. But sodium bicarbonate can be given as a treatment when we see that your creatinine levels are really high after angioplasty. If it is like 2.5 or 3 or 4, in that case, I mean, if it is more than 3, definitely we can go for one dialysis, or we can give sodium bicarbonate infusions. But if it is less than 3, then we can give sodium bicarbonate as a treatment for 5 days or 3 to 5 days. That will be sufficient.
We are giving metoprolol, so patient may get hyperglycemia. So antibiotics should be prescribed only.
Metoprolol, why it will cause hyperglycemia? Patient is not hyperglycemic. Patient's FBS and all, everything was normal. See, normal values I have not mentioned because patient is not diabetic. Patient's GlyHB was really normal, less than 6. Patient's FBS was normal, around 100. Patient's PPBS was around 180. So patient is normal. And metoprolol 25 will not increase. See, this is the treatment of hypertension. We should not be worried what it will be causing, and metoprolol 25 mg will not cause anything. And patient's heart rate, if you have looked at, it was 100. Correct? If I'm not wrong, patient's heart rate was 100 beats per minute. So beta blocker is recommended along with enalapril because patient's blood pressure was really high, 168/72. No, not 72. I think 86 something. So that's why it is recommended. Because heart rate is high. So it is recommended. Metoprolol is recommended. Okay, guys. So now let's go to the guidelines. Is it fine? So these are the references from where I usually read. So the ESC, European Society of Cardiology, has recently, released their guidelines on STEMI, anastomy, everything. Okay, they have revised their guidelines for 2020. So you can see here, these are the guidelines what I usually read, and I'll take you through these. And I also recommend, the guidelines for, guidelines of AHA and ACC, American Heart Association and American College of Cardiology guidelines for management of anastomy. For this particular case, I'm telling. Okay, otherwise there are the guidelines for STEMI, there are the guidelines for other anginas and ACS. So you can look into that also. So, but ACC and AHA has not revised their guidelines since 2014. So they will be definitely releasing their guidelines very soon. Okay, so now I'll take you through the guidelines, but before that, I'll tell you, you can enroll into the clinical internship if you are interested. But this offer, you can, join the internship at the rate of 3,500. But if you are from the particular colleges, you can contact me or you can contact on the further numbers. If you are from our partnering institutes, only selected partnering institute, 5 partnering institutes, you can get it just on the 2,000. Okay, so you can contact us. If you are from those particular colleges, you will get in 2,000, and you can just contact us if you want to, join our internship. Otherwise, normal rate is 5,000. And the price could be 3,500 if you are not from the
online या offline, sir?
Sorry?
Internship or online या offline, sir?
Online, not offline.
Online.
Completely online, virtual. But there will be, as I'm telling about anastomy and STEMI, there are 24 cases in 3 months. Every Saturday, Sunday, one case will be given, and there will be assignment. Every day there will be assignments for you. Okay, so you will be completely learning all the things with real-time cases. Experts from India, from outside, they'll be covering all the posology, clinical and physical examinations, guidelines, algorithms, as I am covering. So everything will be, covered in this internship. That's why, because, people are not able to go to hospitals, they are not joining hospitals, and there are certain colleges which do not have good hospitals where they'll get the teachings. And if they're colleges are even sometimes teaching the cooked up cases, but here you will get the real-time cases, all the real-time cases from the hospital. So if you want, you can join it. Now I'll take you through the guidelines. Let's go to the guidelines. One more thing, guys, our SAS, base and advanced SAS is also starting on Saturday. So if you want to join, you can join in 5,000 only. That will be basic and advanced. Both SAS will be covered in 90 days. 3 months course, that is 4 to 6 hours per week, classes on weekend, and you can join only in 4,999. This is the offer for all of you. So let me stop sharing this and let me go through the guidelines.
Excuse me, sir.
Yes,
Excuse me, sir.
Yes.
Sir, all slide, please send me an email, sir.
No, slides are, see, Okay, now
This slide your are present today. This send me in mail, sir. Please, sir. Requested, sir.
See, my boy, these slides are not for
Sir,
sharing.
some parts, sir. कुछ part छूट गए, sir. Please, sir.
No, see, these slides are, I'll tell you. I'll show you. See, read this. This presentation is a copyright material. We cannot share this presentation. I'm so sorry.
Oh, sorry,
so this,
sir.
but this presentation will be uploaded to YouTube. You can read, you can see the slides. You can, catch this class on YouTube. But these slides are not for sharing.
Sir, one request, sir.
Yes, please.
Sir, your institute on for PB, pharmacovigilance and clinical research in study, sir.
We are starting shortly. We'll tell
sir,
you.
But one webinar, sir, please, sir.
One webinar on PV definitely. We'll come up with a conference on PV. Don't worry. Okay.
Sir, please, sir.
Yes, Ansu will come up. Okay,
thank you,
now
sir.
I'll share, guys. Now I'll share. Okay, I'll share the guidelines. I'll take you through the guidelines. I'll tell you what are the algorithms and what are the actual, evidence-based medicines. What I was telling till now was, what I have practiced, what people have, what people are practicing in the hospitals. Now I'll take you through all the guidelines. Okay. So let me share the guidelines, guys. So this is the ESC guidelines. I'll tell you the simple things. Actually, I have discussed this depth and all. I have discussed this, all antithrombotic thrombolytics as well. I have discussed how to do, but there are many important things what you should know. So these are the guidelines, 2022 guidelines. So they gone through everything. They are based on the recent clinical trials. They focus and they choose. So how they choose, that is the classes of recommendation. If you read this fantastically, they do. They classify all the drugs based on the definitions. Class 1 recommendations. Class 1 recommendations, they have colors for different classes. Class 1 is green, class 2 is yellow, and then class 3 drugs are red. You can see. So these classes are based on the efficacy. So class 1 drugs are very, very much efficacious and very, very much effective. Okay. So let's see how they have recommended, and based on the levels of evidences only, they have classified all the drugs. So here they have given what are the new guidelines, what are the new things they have kept in the new guidelines, and these are the new things what they have added into the 2020 guidelines. That's how this from here it start actually the all new things like diagnosis. So you can see here the diagnosis, the risk factors, low to high risk factors, how they have given. In the high risk factors, patient may go into the shock. He or she may need CPR. So clinical settings should have this. So this is the pain. In the first, they are showing the angina. So in the first case, you can see in the low risk case, you will see that there is very less pain on the upper sternal region, and in the second, it will be in the back side. You can see in the third, in the moderate, it is moderate. So in the moderate case, your whole chest will be paining. Okay, whole area will be paining, and in the severe cases, your pain will be radiating to the left and your jaw. And in cardiac stroke or shock cases, not stroke, sorry, cardiac shock, you may need CPR. And this is how they have divided the ECG as well as I was teaching you. Normal ECG, ST depression in case of stable angina maybe, mild, and ST depression, anastomy. This is showing anastomy, okay? And ST elevation, it is showing STEMI. So STEMI is very much dangerous. In that case, the patient may need CPR or may need shock. Troponin levels may not increase in case of stable or unstable angina, in case of normal or ST elevation, ST depression, but in case of anastomy, troponin T levels will be really increased. And in case of ST elevation, definitely, and it will be increased at least normal to threefold. Okay, normal to threefold it will be increased. Okay, troponin T or troponin I. And this is the triage decision. This is the triage decision. You can see in green, yellow, and red. You can see the triage decision, how the clinicians shift the patient to the triage. or how the patient is shifted. See, if you have ruled out MI, that there is no MI, then you can go for the further non-cardiac evaluations, as I was telling, for the differential diagnosis, correct? And if the patient is in the mild case, first observe the patient for some time, do the troponin, and check out if it is unstable angina. Then in case you can go for TMT and angiogram. And if there are no proper blocks, or if there are no significant blocks, in that case you can just give the medicines and discharge the patient on medications, okay, after angiogram only. But if it is anastomy or stomy, you should definitely go for intervention. That intervention could be PCI, that percutaneous coronary intervention, or like PTCA with the drug-eluting stents, or it could be bypass surgery, CABG. Okay, in that case, definitely you need to go for treatment, further treatments. Okay, and then there is a diagnosis, biomarkers, as I told you, troponin T, troponin I, CKMB. So okay. And they have written everything very, very clearly. And here you can see the conditions. These are the other conditions which are associated with myocardial injuries. The patient can present with the myocardial injury along with tachycardias, along with heart failure. Patient can come with the hypertensive emergency, okay, and MI. Patient can come with the critical illness like shock, cardiogenic shock, or sepsis or burns, and then can get MI. Patient can come up with the myocarditis or Takayusu syndrome. Takayusu syndrome is called as cardiomyopathy. Okay, so cardiomyopathy also can develop MI. So these are the other conditions which can be associated with MI. Okay, which can be associated with MI while patient is presenting to the ER, emergency room, or your OPD. Aortic dissection, pulmonary embolism, renal dysfunctions, and all. So these are the other conditions. You should know these things when you are assessing a patient. When you are assessing a patient's chart, you can go through these things. You can understand these things, like, okay, patient could have these mimicking symptoms also. Patient can have these complications also. So these are the complications and conditions which can appear along with the myocardial infarction. Okay, and here look at this again, same thing. What I was telling there, patient's reference and patients shifting to the ward or discharging or something. So here you can see, the patient is suspected with anastomy. If the troponin T or I is low, then rule out and discharge. Okay. Optional test would be angiography or TMT. Stress testing is TMT. Okay. And if the patient is having, some kind of stomy and troponin is high, keep for, observation and go for angiography and rule out if it is MI or something else. If it is MI, then go for angioplasty. And if the patient is in the high risk or troponin T is more than 3-fold high, in that case, rule in the patient for MI, shift it to CCU, cardio care unit, and go for angioplasty and echo. Okay, sorry. And these are the troponin levels at different conditions. In low conditions, it will be more than 5-fold, and in the high condition, it will be more than 5-fold. In the low conditions, it would be less than 1-fold high. Okay, these are the other diagnostic parameters. So yes, so here you can see they have recommended the diagnostic and risk stratification. If you see, this green is something called the high evidences, or we can say the very, very correlated evidences. So it is recommended to base diagnosis and initial short-term risk stratification based on the combination of clinical history. That's we have seen in our patient has the chest pain and radiating to jaw for 12 hours. I'm correlating with our patient. Have symptoms, definitely. Have the physical findings. ECG was showing anastomy, was showing ST depression and T inversions, definitely. Troponin T was high, laboratory results. So this is strongly suggesting for the class 1. Okay, we should go for class 1 diagnosis and we should directly take the patient for the treatment. So similarly, if it is recommended to measure cardiac troponin for the 60 minutes of the blood sampling, okay, so based on that only we should admit the patient based on the our troponin T. Okay, 12 lead ECG within 10 minutes. If it is showing stomy or anastomy, we should go for the admission. And these are the other things, like if your if your what we say troponin T is less than 3 folds, we should wait for 3 hours. Then again we should go for test, and if it is not recommended, discharge the patient. So based on the diagnosis, they have given all the recommendations. I'll go to the treatment part now, which is very much important. So see, this is antithrombotic recommendations here. Look at this, very nicely they have given antithrombotic recommendations. First, you have to assess patient's age, sex, race, history of ischemia, bleeding events. If the patient has previous history of ischemia, if the patient has previous stroke, you should not give antithrombotic agents. If the patient is on anticoagulants or antiplatelets before or earlier, you should not go for antithrombotic treatment at all. So you have to check all the clinical presentations. You have to check all the comorbidities. If the patient is diabetic, or if the patient is in heart failure, if the patient is in CKD, you should not give antithrombotic treatment. Okay, because bleeding risk will be high. Bleeding risk will be high, right? So in that case, you should be avoiding that. So they have given nicely when you should give and when you should not give. Okay, and see, this is how they have treated, they are treating the patients. So based on that only, first treatment is aspirin. First treatment is aspirin. Along with aspirin, we have to give another, clopidogrel, prasugrel, or ticagrelor. Now, new drug is also in the trial that is called cangrelor. Okay, cangrelor. You can see here in this chart. This is a primary, what we say, the treatment chart. So in the DAPT, in the dual antiplatelet therapy, as I was telling, this is COX inhibitor. Only COX inhibitor is aspirin. Along with that, we have to give one ADP inhibitors or P2Y12 inhibitors, we call it. That could be clopidogrel or prasugrel or ticagrelor. Ticagrelor is the latest drug, which is highly efficacious than clopidogrel and prasugrel. So we recommend ticagrelor. Now cangrelor is, why it is red? Because it is in the trials. It is under the trials, right? Along with that, we can give even GP2B3A inhibitors, injectables, but not for long term. These are not recommended for long term. These are for the short term therapy. Tirofiban or eftimide we can give. Eftipivatide we can give, or tirofiban we can give. These are the GP2B3A inhibitors. But in certain cases, only in certain cases we give GP2B3A inhibitors. Okay, we don't give in all the cases, right? All the cases we usually recommend DAPT. Okay, and if it is C, here you can see both the things what I told in the physiology. One is antiplatelet aggregation, and one is tissue factor is initiating coagulation cascade, and then prothrombin is converting into thrombin, and thrombin is converting fibrinogen into fibrin, and it is making the clot here. It is making the clot here. So in that case, we may need unfractionated heparin or enoxaparin peri procedure only. But peri procedure, why we need peri procedure? See, I'll tell you the history also. You should understand the history also. You should know the history also. Previously, what they used to do, they used to give one antithrombotic, one anticoagulant along with aspirin. One anticoagulant along with aspirin. They have tried everything. Even they have tried triple therapy. Triple therapy means they have tried aspirin, clopidogrel along with warfarin or along with unfractionated heparin. Okay, they have tried everything, but everything was failed. Mortality rate was very high and bleeding risk was really, really high in that case. So final recommendation says that you should go only with DAPT, dual antiplatelet therapy. These drugs are not required in MI. These drugs are required in other cases like, valvular heart problems, or in case of stroke sometimes, that is also NOAC, not normal in case of in case of DVTs, we can go with other these newer oral anticoagulants like rivaroxaban or apixaban, but these are not recommended with antiplatelets because these can increase the bleeding risk, because these coagulation cascade and antiplatelet antiplatelet aggregation or antiplatelet cascade, or we can say the platelet cascade. One we can say coagulation cascade, one we can say platelet cascade. So these two are associated, and these two are finally making the clot. So in that case, we should avoid such drugs together. So here they have recommended all the dose regimen of antiplatelet and anticoagulant drugs in STEMI. Okay, in case of coronary syndrome patients. So you can read it. These are available online as well. And see, aspirin dose, as I was telling, loading dose is 325 mg or 300 mg, And after loading dose, based on the bleeding risk factor, based on the bleeding risk and bleeding history of the patient, we can go for 75 or 150 mg aspirin. Okay, 75 or 150 mg. Side effect, major side effects are bleeding and gastritis. Clopidogrel, again, major side effects are bleeding. Okay, and it has the interaction with your omeprazole, or aspirin has the interaction with your acetaminophen, or we can say the paracetamol, and other NSAIDs should not be given. NSAIDs should not be given with the antiplatelet drugs, because it can decrease, the NSAIDs can decrease the efficacy of your antiplatelet drugs. Okay, so we should not recommend NSAIDs along with your antiplatelet drugs, right? So these are the antiplatelet drugs. Different doses. Clopidogrel can be given 300 mg as initial dose or loading dose. After that 75 or 150 mg, usually 75 mg. Okay, and aspirin also usually 75 mg. In India, outside it is 81 mg or 83 mg. Outside, in Europe and in even Gulf, if you see, that is 81 mg, but in India it is 75 mg. Okay, ticagrelor is all over the world. It has similar dose, 90 mg BID, 90 mg twice daily. Okay, and cangrelor is IV drug, so it is not recommended, and it is under trials also right now. It is not in the market. And all the GP2B 3A inhibitors are IV drugs, so these are also not recommended for long term. These are also can be given when the patient is admitted. Okay, and enoxaparin and UFH also IV drugs, so cannot be used. But fondaparinux, fondaparinux is also subcutaneously, but there are something called newer oral anticoagulants, so NOAC, we call it NOAC. So those drugs all are oral, and those drugs are recommended in other conditions, not in MI. Okay, like rivaroxaban, you can see rivaroxaban 2.5 mg BID for long-term extended antithrombotic treatment in secondary prevention of CAD. Secondary prevention, not primary prevention. Okay, secondary prevention means if the patient is having stroke, or if the patient is having some kind of valvular heart disease along with MI. Remember this, secondary prevention, not primary prevention. Okay, rivaroxaban is not recommended. I mean, these oral anticoagulants are not recommended. These are recommended only for the secondary prevention. Like primary prevention will definitely either valvular heart disease or some other deep vein thrombosis or anything, but not as a primary treatment. Okay, so
Excuse me, sir.
yes, please.
As you said, antithrombotic therapy is not recommended in case of CKD diabetes. And what is the treatment then we should give for in that case, sir?
No, in that case, simply we can go with antiplatelet therapies. In that case, simply we can go with antiplatelet therapy. Yes.
Okay.
Yeah. So here you can see the recommendations for UFH, enoxaparin, and biliverdin. These have the high bleeding risk. Okay, so we cannot recommend. If there is very low bleeding risk along with these drugs, we can give for 1 month, 3 months, but we have to assess every month the things, and we have to assess the risk also. Based on that only we should give. Okay, so these are the recommendations. Again, these are the recommendations for antiplatelet drugs. See, these are the recommendations, class recommendations. So first class recommendation is like aspirin is recommended for all patients without contraindications. When the patient has no contraindications, bleeding contraindications, at the initial dose of 150 to 300 mg or 75 to 250 mg, and at the maintenance dose of 75 to 100 mg only. Loading dose 150 to 300 and maintenance dose 75 to 100 mg for long-term treatment, but without contraindications. Class 1 recommendation is that. P2Y12 inhibitor along with aspirin is recommended in addition to aspirin and maintained over 12 months. So usually now what the newer guidelines says that these drugs are recommended for 1 year, but definitely not, because of patient's lifestyle, because of patient's comorbidity. Depends on that, we continue DAPT. We usually continue after 1 year, we usually continue one drug, either clopidogrel or aspirin with atorvastatin for long term, even for till death, because that is recommended. Okay, so here it is given all the recommendations. Ticagrelor, irrespective of plant treatment, should be given 180 mg loading dose along with 90 mg per day maintenance dose. Okay, clopidogrel can be given 300 to 600 mg loading dose and 75 mg daily dose. So these are the recommendations for all the drugs. And Here you can see all the treatment extended things. And here you can see the risk factors. Okay, thrombotic class risk and moderate thrombotic risk, where you should not give the thrombotic, antithrombotic agents. As I told you, risk enhancers, diabetes could be risk enhancer. History of recurrent MI could be risk enhancer. Multivessel CAD could be risk enhancer. So we should not give in that case. CKD with EGFR 15 to 60 should be, like avoided when you are giving antithrombotic agents. We should not give in the, CKD 4 and CKD category 4 and 5. Okay. So yes, that's all. And patient counseling, you all know how, what should be the counseling for the patient, that you can read all things. I'll share with you guys. So I think I took the class for more than 2 hours now. But definitely when we'll teach, it will be more than 2 hours only, one class. So I'll stop sharing this. So patient counseling, I'll leave on you. You can, just read it, and you know that how to counsel the patient. Okay, guys. So any questions now? I think I'm also tired.
Thank you, sir.
Thank you, sir.
Thank you, sir.
So any question to me right now, guys?
Yes, sir.
No questions, guys? Any question to me?
Sir, I'm second year right now. So do you think clinical internship will be needed?
Sorry, Sabha, what you were telling? Alice, your microphone is on.
Sir, I am second year right now. So do you think the clinical internship will be needed right now?
Sorry, in what year you are now?
Second year.
Second year PharmD?
Yeah.
Then I'll say it is not recommended right now.
Okay.
It is recommended. I have written in that it is recommended for 4th year, 5th year, and 6th years interns. Why 4th year? Because they should understand the cases and they should understand the therapeutics from now only.
Sir, eligibility, sir, in internship, sir. Only Form D and other.
It is recommended for PharmDs. B Farms can, if they are interested in pharmacy practice later on, then they can join. Otherwise, I will say why to waste your money if you're not going to practice.
So, sir, one friend pharmacology department, sir, in Fraser. Hello.
Hello, Ansu. Yes.
Sir, one friend in pharmacology department, sir.
If it is helping them, then they can join. If it is not helping, then no problem. I think
okay.
They should think before joining. Everyone should think before joining.
Okay, sir. Okay, thank you, sir. But PB in webinar, sir, please organize, sir.
Yes,
in
yes,
one.
yes, definitely, Ansu, definitely. We'll
okay, thank you, sir. Thank you. Thank you.
Okay, guys. So if no questions, we can leave. Thank you very much, everyone, for joining and listening. I think there were 100 participants till the end. Thank you very much. We'll see you guys. You will get the email with these links. Okay, Dr. Tarun, thank you very much. We can stop recording and end the session.
Yeah, definitely. Thanks a lot, Dr. Ajit.
Thank you, everyone.
Thank you, sir.
Thank you, sir.
Thank you, sir.
Thank you.
Thank you, sir.
Thank you, sir.
Thank you, guys.
Thank you, sir. Thank you, sir.
Thank you, guys. Thank you very much.
Hello, sir.
Yes, Sheikh Adnan.
Sir,
Hi,
could you
Adnan.
please? Yes, sir. Sir, could you please share us your YouTube channel name?
Yes, definitely. Okay, wait. I'll share the YouTube channel link right now.